各位观众，大家晚上好，我是 3Shape 中国市场部的赵云迪。那么非常感谢参加我们今天第一场无牙和有未来系列线上研讨会。那么作为一家全球领先的数字化牙科解决方法提供商，3Shape 一直致力于通过创新的口内扫描仪和数字化平台，为患者和牙医提供更加高效、精确的诊疗体验。我们的技术不仅帮助诊所提高工作效率，更通过 AI 和自动化的力量，使得个性化治疗成为可能。那么本次研讨会正如其名，专注于现今社会上的无牙盒问题，特别是在老龄化日益加剧的今天，无牙盒已经成为影响众多患者生活质量的关键议题。那么无牙盒患者的功能和美学需求都十分特殊，传统的治疗方法往往存在流程长或者精度受限等问题。而我们今天的系列研讨会，正是要向大家展示数字化技术是如何突破这些瓶颈，从而为无牙盒患者提供更加舒适、更加高效的治疗方案。那么我们本次第一场也特别邀请到了美国 Aspen 牙科集团的 Eric Kuchka 教授，为大家带来数字化义齿修复流程从理想照进现实的课题。希望通过今天的分享，让大家能够深入了解数字化无牙和修复的优势，并从中获得启发。So to begin our first session, we are honored to have Dr. Eric Kuchka, who will present on the topic Digital Dentries from Imagination to Reality. So please join me in welcoming Dr. Kuchka.
Welcome to 3Shape Discover's lecture, Digital Dentures, Imagination to Reality. My name is Erica Kuchka. I'm the Vice President of Clinical Removable Prosthetics and Design Technologies at Aspen Dental and the Aspen Group. I'm so excited to be here today with you to talk to you about how we are going to reimagine digital dentures. So I want to welcome you to the presentation today. Today, during the presentation, you're going to get great knowledge and understanding of the digital workflows, material sciences, milling versus printing, and really and truly seeing the evolution of digital removable prosthodontics. So welcome again to 3Shape Discover. Removable prosthodontics is a significant part of dentistry. It has been neglected in both practice and in education over the past several decades. Millions of patients need our help in this important area. And that was from Gordon Christensen in 2006. Removable prosthodontics, a forgotten part in dentistry. And I can't tell you how much that hits home, how relevant that is even today. There are millions of patients, hundreds of millions of patients rather, globally suffering from edentulosum, which we're going to talk about. But really and truly, dentures were never considered the sexy part of dentistry, the interesting part of dentistry. In my appointment now at Aspen Dental, onboarding new doctors each and every single day, most of them are not excited about removable. People that I talk to in the industry are not excited about removable. But I will tell you, digital dentistry is changing that. Digital technology is changing the landscape in everything that we do. Edentulism is a debilitating, irreversible condition and is described as a final marker disease for burden for oral health. And edentulism can lead directly to impairment, functional limitation, physical, psychological, and social disability, and handicap. And that was published in 1988 by Locker. I think when you look at this photograph, it does tell you how debilitating this disease can be. And I think we as individuals often forget and negate the thought process of what goes on in edentulism. If I was to tell you today, I would be removing your hand. Think of how that would affect you emotionally, psychologically, and personally. To have to go through that. To have to think that you're not going to be able to write. How you're going to put on your clothes. How you're going to open doors. How you're going to cook. How you're going to live your everyday life. It is truly a handicap, and it is extremely unfortunate, and these patients need our help. And because removable prosthodontics have been ignored for so long, there are so many of these patients that are not getting the treatments that they deserve. And again, despite the development and curative preventative dental care over the past few decades, edentulism continues to be a challenging problem in healthcare. And why? Limited access to care, therapeutic causes, periodontal disease, morbid or genetic diseases, lower income and education, iatrogenic dentistry, trauma, low absorbic acid, history of smoking, cancer. These are all of the factors that are affecting edentulous and continues to be a problem in our society. Further to that, as I've been mentioning, these edentulous patients need our help. They need our service. And removable education in academia is also suffering. Providers are often graduating with minimal experience and low graduation expectations. Many students do not feel comfortable, nor do they enjoy their complete denture education. Clinicians' discomfort levels are enabling them to abandon their clinical learned skills in their academic institutions. A 1984 and 2009 survey indicated that 50% of definitive impressions were not border molded, and 75% of them were set on a hinge articulator, average value. Asynchronous delivery dates back as early as 1975 and has evolved in various forms. So we've talked a lot about the need to treat the edentulous patients. We've talked about the lack of education. We've talked about how removable prosthodontics has really been abandoned. And what's so interesting about that is 25% of the global population is 65 and older suffer from edentulism. 703 million patients globally are driving the need for dental labs to produce removable prosthetics. The ACP published last year 120 million Americans missing more than one tooth and 35 million fully edentulous Americans in the United States. And one really interesting publication was back in 2014, which was called The Top 10 Things Denture Patients Told Us About Their Dentures. 45% of those patients reported poor fit, size problems with their dentures, and 48% of those patients were unsatisfied with their current dentures. That just goes to show you the patient dissatisfaction, the uncomfortable process that's associated with removable prosthodontics and unprofitable. A 2017 Dentsply Sirona study demonstrated an average of 5 to 10 appointments post-delivery in order to get a removable prosthesis to be appropriate. That's post-delivery. So when you think about those factors, it obviously leads to why there's $1.7 billion spent on adhesives every year, and that's expected to grow by 2030 to $2.7 billion expected to spend. These patients need our help. And the growing demands are very accurate when you're spending $474 million on the expected growth of denture cleaners by 2028. With the high need of demand, with the growing edentulous population, unfortunately 50% decline in dental labs. And this was published in 2019 by Aegis, by Jason Mazda, The Effect of Consolidation Inside Dental Technology. So we have a high demand of patients. We have a low quantity of dental labs to produce this work. What do? We have to change. We have to evolve. We have to go beyond what we know to be true. And removable prosthodontic therapy, from a clinical perspective, really hasn't changed in decades. And I'll talk more about that. But does the process need to change? Does the manufacturing need to change? And when you look at this slide, they're both automobiles. They both have 4 wheels. One is electric, one's using an engine, of course. But really the founding principles of getting from point A to point B are still institutional and foundational to the driving forces. But the car on the right is lighter. The car on the right is faster. The car on the right uses less energy. The car on the right is more efficient. The car on the right is smarter. The car on the right can do all these things that the car on the left just could never do in an analogic or conventional process. Everything we do today is digital. And what I'm so passionate about is creating what I call removable unnoticed. Removable unnoticed should be unnoticed by the patient. It should be unnoticed by their family, by their friends. A removable unnoticed prosthesis should be one that is so comfortable that the patient can live their daily life feeling like they are truly a person again, not living with that handicap, not being negated by these error-prone processes that we've talked about before. Because it's not a patient, it's a person. So let's talk about this evolution, really why we're all here to discover today, the evolution. Over 6.2 million removable cases were generated in 2023 alone, and you can see the trajectory and the growth of digital denture solutions from partial denture frameworks, custom impression trays, and full dentures. Interesting enough, when you look at the growth, the most insurmountable one is the partial dentures. Why? As I mentioned earlier, 120 million Americans are missing more than one tooth. But it is very interesting to see the growth happening in the removable space in digital technology. So I'm sure you're asking yourself, okay, that all sounds really great, but why? Why is digital so much better? Reduced chair time, strength, workflows, electronic preservation, materials, retention, uniform thickness, accuracy. And I'm going to talk about all of these factors today on this journey as we discover digital dentures. And these are just some of the factors, but these are the most important factors that really are institutional to the success and the benefits behind digital dentures. And last but not least, consistency. Consistency across the board of the tooth arrangement, consistency of the denture base thickness, as we talked about, consistency that each and every single time you're going to be able to get a design and a manufacturing process that you can trust. Unfortunately, we have the degradation of dental labs, and we also have the degradation of talented dental technicians that take decades to learn how to set teeth anatomically, physiologically, and functionally correct. One big advantage of digital dentures, as I mentioned, with the degradation of dental labs and dental technicians, the difference between active and passive time is incredible. 126 total minutes of average labor time for a removable prosthesis versus 30 minutes of labor time in a digital perspective. Let's talk about accuracy and trueness. And this study that was published in 2016 really demonstrated the difference between pack and press, pour technique, injection, and CAD/CAM. Now, what this study proved is that there's more accuracy and trueness in a CAD/CAM milled denture at the time when it was compared to the other restorations. Let's talk about uniform thickness. Uniform thickness, imagine how that feels to a patient when you are truly conforming the patient's denture to the palatal vault, when you're truly conforming the lingual concavities to the patient's tongue, giving that ability to create neuromuscular, physiological neutrality from placing the teeth in the neutral zone, but having those beautiful contours. It is truly something that was once thought to be insurmountable, but today is a reality. And again, as for the title of my presentation today, bringing digital dentures from imagination to reality, I really want you to pay close attention to what you're seeing on the screen. You're seeing an upper denture with a 2.5 millimeter uniform thickness, a lower denture with a 3 millimeter uniform thickness. Look at the occlusal plane. Look at the curve of Wilson and the curve of Spee, or the Monson curve. Now, this is a lingualized occlusion that you're seeing here on the lower, but look at how beautiful and perfectly arranged those marginal ridges are. The central fossas over the center of the ridge, the palatal rugae on the upper, the tapered, feathered distal terminal end of that maxillary denture. All of those gingival margins, the festooning, the stippling, all of these things are controlled by CAD/CAM software. They are controlled by the CAD/CAM design. And you can imagine how comfortable that feels for the patient, how self-cleansing, And what I also negated to mention with uniform thickness is strength. Strength of the restoration, because we do not have areas that are too thin or too thick. We have perfect uniformity throughout. And the question I always get asked as of late, milling versus printing. I've spent many years. My journey was started with milling back in 2014, where we were milling a denture base and bonding denture teeth to that milled base, putting that back in the mill, and then doing the final basal reduction. And there's been so many advancements in digital technology, and especially with Avident having one of the first monolithic milled dentures, and then getting into all types of different companies that have truly innovated. Dentsply Sirona, Ivoclar Vivadent, Zircon Zahn, Vita, Heraeus Kulzer. There has been so many advancements, Armand Gerbach. And really today, the future of digital dentistry, or the present rather, is 3D printing. The future of digital dentures is monolithic printing, which is polyjet technology or multi-jet technology, where you're actually printing the denture in one solid piece. But let's just go back to additive manufacturing versus subtractive manufacturing, or milling versus printing. Milling being subtractive, 3D printing being additive. When 3D printing really first came into the industry, one of the first materials was the Denka resin, and it was revolutionary to be able to print a set of base and teeth. But the challenge with those materials were they did not have the fracture toughness to resist work of fracture, fracture load, fracture toughness, occlusal forces. And what's really most important when you talk about milling versus printing, I think the one thing about milling that 3D printing doesn't have is less error-prone process with the overall process, especially in post-processing. And post-processing in 3D printing is one of the most, if not the most important aspects in the 3D printing process. It is how the restorations are post-processed, from the cleaning with the IPA alcohol to the fusing of the materials when you're bonding the base and the denture teeth together. And then lastly, the polymerization of the photopolymers of the stereolithography generated denture base and denture teeth to then fuse them together to do a full polymerization. But what we have found to be one of the most necessary aspects of a performance of a restoration, irrespective of conventional, milled, or printed, is fracture toughness, and in particular to the work of fracture. And when you look here, you can see some of these studies that were done by Loma Linda University, Dentsply Sirona, Ivoclar Vivadent's internal data as well. And you're seeing where you have that work of fracture. So the ISO standard for a high impact base work of fracture is 900 joules per metric square. The IvoBase CAD supersedes that. The SprintRay Apex supersedes that. And the Lucitone digital print system at 25C exceeds that. And then at 37C, with its unique material, which is called body activated material, which is a 4D polymer which doubles the fracture toughness at body temperature while the patient's wearing the denture. And again, when you look at this study here on the left-hand side, comparing a milled CAD disc to Lucitone press pack, the Vita Vionic base, IvoBase high impact, IvoCap, Lucitone 199 success injection, ProBase high impact, really able to see where these fall on a fracture work or the work of fracture across the board. So really my philosophy has always been, if it needs to be the same or better, right? Why am I going to make a change from my conventional methodology into a digital methodology if it's not the same or better? And today, both milling and printing have those attributes. Now, it's material agnostic, of course, but it's important to know that there are viable methods of 3D printing manufacturing. And one of the studies that we looked at as well at Aspen in collaboration with Loma Linda University is the utilization of T-bars. And placing T-bar supports on the manufacturing process can truly change the overall dimensional accuracy and trueness of the restorations, both at 50 and 100 microns. Another factor to look at as well, because now we don't have denture teeth that are individually either bonded to a milled denture or polymerized cohesively in an injection molding process. which is what the original push-out tests were, right? So it's comparing, do you have an adhesive and a cohesive failure with a standard set of denture teeth? So what we decided to do was modify the push-out test and use fully assembled dentures that had monolithic arch of teeth. And you can see both with the maxilla and the mandible, we had an overall standard mean of almost 1,000 Newton centimeters to truly create a cohesive fracture inside of this denture-based resin. We tested all different materials for this milled. This particular study was done with Apex, but we did this with loose tone digital print as well and saw even greater numbers. So again, this is a loose tone digital print denture that you're seeing here, but this is, really amazing advancement in technology, and the balance of flexural strength, flexural modulus, and fracture toughness really create truly a denture that you can be confident in today. Now, again, what you're seeing here, these are 3D printed dentures. The left side is the Sprint Ray Apex denture, the right side, the loose tone digital print. Again, as I mentioned, there is a vast majority of commercially available milled and 3D printed dentures that are available today. One of my favorite articles was published here by Dr. Wendy Clark, which talks about the reduction in chair time in an academic setting. I really encourage you to grab this QR code and have a read inside of this article. One last thing, there's a lot of conversation that you can't repair digital dentures. So we did a scientific validation for both relining and repairing of digital dentures with the Sprint Ray Apex and the loose tone digital print material, and found that we had successful results from a cohesive manner, in the bond of these materials for both indications. You could also utilize the Dentsply HIPAA material as well to repair the loose tone digital print, printed restorations. Of course, any PMMA, milled PMMA, whether it's Ivoclar, Avident, Vita, Dentsply disc, those can all be repaired with PMMA because it is PMMA materials. So let's talk about our pathway. I hope that you've been engaged and really and truly inspired by what is possible and the evolution of digital dentures from the conventional process. As I mentioned before, there are so many error-prone processes along the way. From the time the patient calls, when do you get them in? How do you treat them when they walk in the door? Your body language with the patient, how soon you can take their impressions. And I want you to think now about all the error-prone processes, from measuring your water and powder for your alginate, how you're spatulating that across, how you seat that tray, how long it takes before you pour that impression, how much expansion and contraction of the gypsum, how well adapted is the custom tray, are the borders too short, is it too thin, how is your border molding done? Did you get enough of the border, not enough of the border? Did you use compound, isofunctional, heavy body, light body? How long did you take to pour that model? Did you beat and box? Then when you're making the bite rim, is the base plate fully adapted? Is your post-dam engaged appropriate enough? Then when you go to do your centric relation registration, are the base plates stable? Is the patient in a repeatable position? Do you have the right vertical, right tooth size, tooth shape markings, incisal edge positions, camper's plane? All these factors, I can continue to go on. Is the articulation appropriate? Did the plaster shrink? Are the teeth set in bilateral balance? Are the line angles appropriate? Are they on the center of the ridge? And then we can continue that to the trine. Is it a stable trine? Is the patient excising their appropriate phonetics? Is the centric relation you're checking truly stable? And then, of course, when it comes to processing, we have polymerization shrinkage. Did we trim too much of the borders? Not enough of the borders? How much has the occlusion changed? How's the fit changed? Those are all things that we have to consider and we have to think about. And that's a 5-appointment standard workflow that we've discussed. And I want to talk to you because the error-prone process is mostly come because we don't have a reference point. We have ridges. Of course, following biometrics, yes, we have incisive papilla, canine point, center of the ridge, Pound's triangle, mid-palatine sutures. We have all that, but we have to create that from a spatial perspective when we're registering centric relation. So when you think of a standard analog workflow, as I just mentioned, alginate impression, border molded custom trays, bite registration, wax try, and then final processing, trimming, and polishing. How does that change in digital? I want to be very clear with the clinicians. Your clinical workflow that you have done today or have been doing for decades does not have to change. You can continue that same workflow, but you can incorporate digital technology. You could scan those alginate impressions and have a digital custom tray made and then pour that model, make your bite rims, or you could stay in the analog flow all up until the bite registration. From there, you scan those stone casts, and then you will get a monolithic, or you can have a base and a pink and white try-in as well, depending on the lab that you work with. From a cost perspective, less expensive, of course, to have a tooth-shaded monolithic try-in. You can paint those with a Sharpie. You can draw on them. You can add wax to them. You could add composite to them if you want to really simulate the gingiva. From there, then you can have your milling or printing done. So really and truly, digital dentures doesn't mean you have to change your clinical workflow. A lot of conversation about intraoral scanning, edentulous intraoral scanning. Yes, this is possible today. Absolutely, this can be done. There was a wonderful step-by-step that was published in April by 3Shape Online for Dr. LaRucco's scan strategy. Check that out. But here's what I'm here to talk to you about today. I'm here to talk to you about the pathway to digital dentures, which is how you should get into digital dentures, which is with the reference denture technique. Every patient's denture tells a story. When I look at this denture, what do I see? Tooth size, tooth shape, tooth position, occlusal wear. I have vertical dimension, I have lip support, but it may not be appropriate. But I have all that information there and I want to go back to that. Irrespective of how it looks, it's all there for me. And right, the average lifespan or frequency of replacement is 5 to 7 years. Right? But patients will wear those dentures much longer than that. Patients may wear the denture 15, 20 years. And I thought this was a really great statement. Successful denture treatment is not 100% determined by which impression tray, which material, which articulator or occlusal scheme we use. The most predictable factor in denture success, how the patient feels. And this was published by Carlson back in 2014. The existing dentures of our patient, even if unsatisfactory, can be used in diagnosing and planning treatment and the actual treatment involved in complete denture services. So here is that patient's denture that I showed you. Now I want to talk to you that this is any colleagues that I've talked to have been doing digital dentures now for over 10 years. And the simplest way to get into this is with the reference denture technique. And by the way, if you don't have an intraoral scanner today or a desktop scanner and you just want to get into digital dentures, partner with a lab that's able to do a pickup and drop off service. Okay? Just like a Reline. If your lab locally does digital dentures, you can do the reference denture technique and treat it like a Reline. But I would encourage you, if you don't have an intraoral scanner, to invest in an intraoral scanner today. Because there really and truly isn't anything or any indication in dentistry that we can't scan with an intraoral scanner today. And that's your gateway and pathway into digital dentistry and digital dentures. When I look back to my time and how I started in 2014, was I was sending clinical records to a lab, a research and development facility at that time because it was in its infancy, and I would get the manufactured product back. From there, I bought a scanner so that I could scan my records and send. And then I bought a printer, then I bought a milling machine, then I bought another scanner and another milling machine and more printers, and really went through that evolution in that regard. But really and truly, enabling yourself with an intraoral scanner will truly become your pathway into digital dentistry. So let's talk a little bit more about this case. I want to show you the power of digital dentistry, of how we can produce digital dentures no matter where we are in the world. And this is a colleague of mine, Dr. Nelson Silva, who's working in a patient's home doing scans of his denture to create the reference denture technique. This was never before possible of how we can transfer this data internationally. So what's happening right now, scanning the impressions inside the denture to send back to me, this was happening in Brazil, sending back to me in Canada for me to do the denture design, and he'll do the printed try-in, which we'll talk about. So there's our upper and lower impressions. You could see the two-step functional impression was done. Now, you saw Dr. Silva doing the scanning. It's important to follow the necessary and appropriate scan strategy. I'm going to go back so you can scan that QR code. This was a partnership between myself and 3Shape for the reference denture scan strategy. You need to follow this strategy to have the most accuracy and trueness in your scans. So let's go through here. Here's the initial. There was our try-in, and then the final. So again, scan sent, try-in designed, try-in approved and or modifications, and then delivered. So let's go deeper into that path forward. That's really a high level. I want to walk you through a case from start to finish. The path forward can be either taking the impressions directly inside the denture, or you can do a denture duplication technique. So for those of you that don't have a scanner, I recommend you get yourself a Lang's duplicator, duplicate the patient's existing denture in a fluid resin material, and utilize that to take your impressions, and then that you can ship off to any lab in the country or around the world to do your digital denture process. It's necessary to perform a comprehensive examination of every potential denture patient. Many unsuccessful dentures are the result of dentist failure to identify potential problems before beginning therapy. And I like to ask these simple questions. What do you like? What do you not like? What are you expecting out of this treatment? And then it's important for us as the clinician to put unrealistic expectations into reality. So let's talk about smile design. Smile design, of course, enables us to have great patient excitement, but also enables us to be able to evaluate where do we want to make changes? Where do we want to make improvements to the aesthetics, the tooth size, the tooth shape, the tooth position based off of the existing situation? So of course, we're going to measure our vertical dimension of occlusion before we get into taking our closed mouth functional impressions. So we like to recommend a two-step closed mouth functional impression, heavy body border, light body wash on the intaglio, take a centric relation registration, and then reaffirm the vertical dimension. Now, if we're opening the vertical, you may want to use green stick compound or wax to open the VDO of the patient if they're significantly overclosed. You've heard it today. You now have every solution possible from Trios in order to enable yourself to get into digital dentures and digital dentistry. Of course, on the lab side, a full suite of scanners from the E series and into the F series for all of your scanning needs. As you can see here on the screen, this is showing you following my reference denture scan strategy, getting the perfect scans with the most accuracy and trueness, making sure that you're following that path will create a true, incredible scan data for the digital dental technician to design. Also including the bite scan. And I want you to sit for a moment and think of how long it would take to pour an upper and lower master cast, beating, boxing, pouring, trimming, and then articulating that. You can scan the upper and the lower and the bite in under 5 to 10 minutes. The average person takes about 7 to 10 minutes once they really get their... Imagine scanning these impressions in under 10 minutes versus the time it would take to do beating and boxing, pouring that master cast, and then going back and articulating it. Truly, truly, truly revolutionizing the efficiency, effectiveness, and the precision. So once we have that data scan, the designer is going to then utilize that and the photography that you're providing. It's important to provide those initial situations. You don't have to do a smile design. I encourage that because I think it's great patient excitement. But even if you sent the lab the high smile photo as a diagnostic. And then of course, following biomechanics. So although we have this reference denture giving us a reference, we're going to utilize that in order to enable us to make the appropriate decisions to make sure that we're following the biomechanics of tooth arrangement that has been institutional for decades. And you can see here on the screen when I'm merging the new design over the old design and having that visibility of the old or the initial situation versus the new situation can be very powerful when you're looking at the photograph or even just looking at that from a diagnostics perspective, which is why in the conventional world we take diagnostic casts with a push-down impression inside of the alginate to give the dental technician a visibility to the size, the shape, the position of the teeth. But now in digital, we have that ability to visualize that. I want you to think about one further step to this. Imagine you as the clinician with the digital design technician reviewing this on a Teams meeting or a Zoom call or over TeamViewer and being able to say, no, move those teeth a little bit palatally. No, bring the teeth a little bit labially. Bring the teeth lingually. Bring the incisal edge up. Make that tooth a little bit wider. Rotate this tooth. Rotate that tooth. At a moment's notice. I want you to think about how powerful that is. So from there, we're going to print a monolithic try-in. So I call this a functional try-in, a trial denture, a blueprint, or a prototype. And what is the purpose of this? The purpose of this is to evaluate fit, form, function, aesthetics, and phonetics. And these should be 3D printed. There's really no viable reason to mill these. These should always be 3D printed. Again, you can do it in base material and tooth material, or you could do it in the tooth shade that the patient's going to be requesting. So again, we're evaluating fit, form, function, aesthetics, and phonetics. But what I find so powerful about a digital denture try-in is the fit is exactly the same as the final. No longer are we making excuses with patients saying, don't worry, it's going to fit better when it's done. Don't worry, it's not going to look like that when it's finished. Don't worry, your bite feels a little bit off, right? Not worrying about, as a clinician, checking centric relation, having that patient tap, 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 bite up and down, smiling and not being skewed by that upper stabilized base plate being loose. And look at what we're able to see. Midline, high smile line, buccal corridor, tooth size, tooth shape, vertical dimension, and then we communicate those changes. Why in analog did we sometimes have to do 2 try-ins or 3 try-ins when we needed to move midlines or occlusal planes? Because we had so much doubt that the dental technician couldn't exactly provide the changes that we're requesting, and we just want to make sure. In digital, if you're requesting a midline to be moved 0.5 millimeters to the patient left or right, that can be done seamlessly. Opening and closing verticals, moving incisal lengths, rotating occlusal planes, all done simply. Also, modifications can be done with a higher level of efficacy and precision, whether it's taking a new centric relation record, taking a new impression, or doing both. All you have to do is grind on the posterior teeth, not like an analog where you have to remove each tooth, melt the wax, take a centric relation check, re-articulate, reset. If the bite's open or the bite's off, simply grind away the premature contacts excessively and take a verification record. So here's the final results of this case. This is a Lucitone digital print denture that you're seeing here for this patient. And if you recall the existing situation here, so as we discussed earlier, these patients really do need our help. So let's go over a few more reference denture examples. So let's look at this patient. Patient comes in, denture's 10 years old, worn out occlusion, VDO is overclosed, but we have enough information. Yes, we can see the occlusal plane is canted. Yes, we can see the buccal corridor deficiency. Yes, we can see the incisal display deficiency. However, I want to remind you of one thing. We talked about this earlier, and what does a patient want? What are they looking to achieve? And putting realistic expectations into reality. But one thing that I didn't talk about is this patient's been wearing this denture for 10 years. Good, better, bad, or indifferent, they're happy with it. So we'll start with our smile design. We'll go ahead and do our impressions and a bite registration, scan all of that data, and then do our monoblock try-in. What are we looking for? fit, form, function, aesthetics, and phonetics. Now, in this particular scenario, I opened the video a little bit too much. We don't have enough freeway space between the upper and lower teeth, so we have to close the video in order to enable that. And that's the goal of and the purpose of doing a monoblock try-in. There are many people out there that do a 2-appointment reference denture and skip and negate the try-in, but I want to tell you that millimeters matter. And I think that doing a monoblock try-in will render you the ability to make those necessary changes. Because when you go right to finish, which again is possible, you're not inclined to make those changes because the denture's already been finalized. But when you do that with a monoblock try-in or a monolithic try-in or a try-in, it enables you to evaluate fit, form, function, aesthetics, and phonetics, and encourages you and enables you to make those changes. Again, milling or printing, and I think doing some nice post CAD/CAM artistry doesn't always have to be beautiful composites, but even just individualization between the teeth, creating some additional surface texture can really render a beautiful result. Going back to the initial situation of the patient, the monoblock try-in, and then the final. Look at the improvement across all three of those images to the final restoration where we were able to create truly a beautiful natural smile. Now, we talked earlier about the reference denture technique if you don't have an intraoral scanner, or this could also be a use case if the flanges are overextended and you want to grind them down. If the buccal labial flanges are too far protruded or too thick, you can also grind those down. This is a way that you can make as many modifications to the existing denture as possible. Even in an instance when the existing denture is over open, showing too much teeth, you could do the denture duplication and literally grind off the incisal edges and the posteriors, similar to what you would do with a bite rim, to enable you to still do a reference denture technique with the denture duplication. So I'm going to walk you through this technique. Here's the existing patient. I made this immediate denture almost 10 years ago, and the patient's chief complaint was the fractured lateral incisor and the canine. He could eat whatever he wants. I eat apples, I eat corn on the cob, everything's perfect. I want you to remember, listen to the patient. And like Carlson said, it's not the impression tray, the workflow, the articulator, the occlusal scheme. It's how the patient feels. So knowing that this patient feels comfortable and confident, his only chief complaint is the fractured tooth. Now he is in an interim prosthesis, which is why it worn so drastically. We're going to make some improvements there. But this is where either a direct reference denture, or if you don't have an intraoral scanner and you want to work with a lab that can pick up or that you could directly ship these restorations to. So again, get a Lang's duplicator, duplicate the existing case, take heavy body, light body wash impressions, take a new centric relation record, take photos, and be very prescriptive of what you want to change. Again, you're either going to ship this physical impression of the denture duplication to a lab if you don't have a scanner, or you're going to scan it using an intraoral scanner or a desktop scanner. Now, I want you to see what's beautiful again about the digital design technology. Looking on that monitor on the lower left-hand screen is the actual image screenshot of the new teeth superimposed over the original scans of the restoration. So giving us that visibility to be able to see the existing situation and the new situation. So here's my monoblock try-in. You can see that I'm showing a little bit too much lower teeth on this instance, and I was slightly off on the midline. So I'm going to make those corrections. I'm going to close the video 1 millimeter and then go ahead and proceed to final. This is a milled denture that was done with a monolithic ivotion. So there's our before, there's our try-in. You could see that deficiency in the midline, and then our final. So really and truly enabling great success. I want to walk you through one more case. So this is a patient that I treated for immediate denture therapy and then came back again for her final definitive therapy. So that was the immediate denture that you just saw there. So here's an instance of a denture duplication. Again, I didn't like the labial profile. I thought it was a little bit too far forward. So what I was able to do was actually reduce this labial profile to give me a guide, no different than I would do with a wax rim. And I just did that by simply grinding on it, then just doing a little bit of a polish. Heavy body, light body, new centric relation record, scan those records, bringing that into the design software. And I want you to see in this video now, this is a very, very nice way to illustrate to you how that design software works, having the ability to visualize the existing situation and making the necessary changes. I wanted to incorporate a little bit more of a rounded, more oval tooth for this patient, but look at how I can see where the teeth are on the center of the ridge, the occlusal plane, and I always have that existing design, as you see here, as my initial situation. You could see I brought the teeth palatally further than what the original situation was. So when we go ahead and look at that initial try-in, still showing a little bit too much gingiva and just a little bit too far labial. So again, because I didn't go right to finish and I did a try-in, I'm able to make those changes, which is what you see here. This is also a milled denture. This is a milled Ivotian denture actually, and you can see the difference between my monoblock try-in and my final. I really hope that this has given you a lot of confidence in how to enable yourself to do the reference denture technique, whether you're doing it directly in the denture or you're doing a denture duplication. Of course, you can do artistry with CAD/CAM. And how do you enhance that? With gingival composites. And here's an example of an SR Nexco case on a milled denture that was a collaboration between myself, Nelson Silva, and Renata Vano. International collaborations. This was a collaboration I did with Dr. Rupert Monkhouse in the UK, where he had a patient that he wanted to do a digital denture case with. First digital case, but we stayed analog. We took alginate impressions, we did bite rims to get the vertical dimension, mark the midline, the high smile line. We did a monolithic try-in, confirmed fit, form, function, aesthetics, and phonetics, and then we went ahead and finished the milled dentures. And the beautiful composite work here done by dental technician Ricardo Soares out of the UK. You can see how beautiful the results were for this patient. Let's talk about immediate dentures. Here's a young patient that needed immediate dentures due to the terminal dentition situation that she presented with.
Family pictures, being able to get a good job, go out into the world and have friends and go to the movies and do normal people stuff, smile, and to not be scared, to feel like a person. Once you lose your teeth, you don't feel like a person anymore. You feel lost and scared. You're not yourself anymore. You lost one part of you that people judge about very, very harshly. I just want to be home and be happy and smile, and I can finally do that. We're getting very close.
So we're looking at the existing situation. We can see the position of the maxillary central incisors, the position of the mandibular incisors. We're going to open the video. We're going to decrease the length of the lower central incisors. This patient actually was getting dental implants in the lower, so we're able to do an alveoplasty. And again, you can do alginate impressions, porous stone model, or you can do direct intraoral scanning. What I find very unique with the digital system is the digital tooth extraction. It's a very, very nice tool. And just like in the reference denture technique, when you're doing your immediate denture design, you have the ability to see the tooth size, shape, and position consistently. So imagine those team viewer sessions with the dental technician being able to say, bring that incisal edge just a little bit higher, just a little bit lower, bring the teeth off the ridge, on the ridge, all those types of changes that you have to make.
Happy, confident, able to actually open my mouth and not fear how people are going to look at me and I could actually go to the mall and shop and not rush and look at people while I was talking to them, while I was cashing out, while they were asking me questions. I felt like I could be me again and not have to hide. It's tough, it's hard, it's scary, but if you push through and you have that team behind you that's there, it's worth it. You just stick to it and know that in the end, it's all going to be perfect. Get a job that I can like and love, be able to go out and be with my children, bring them places they want to go to, and just enjoy my life, find out who I really am, not the person who I was always scared of bringing out, and enjoy myself. They're all so happy for me, and genuinely just amazing love from everybody. I would say to them, they are life changers. They literally changed my life only for the better.
And here's how we were able to truly change this patient's quality of life. And this was 2 weeks post-op after delivery of this digital immediate denture. Again, we talked a lot about diagnosing, treatment planning, photography, and the importance of that, and digital communication. So this was a case that I did with Dr. Nelson Silva. Patient was seen in Brazil. I did the CAD design here in Canada. And what we were able to do is also design a surgical reduction template to do the necessary avioplasty for the patient, and then produce that final digital denture. Again, if you're not doing a surgical reduction template, also very easy to make a standardized surgical stent. Surgical stents that have been used for decades. All that is a digital base plate on the extracted model. No more do you have to make a duplicate and make a suck down. You can do that all digitally. There's the before and after, and you can see the change in the labial profile. If you want to learn more about this entire technique, I want you to sign this QR code here, and you can go ahead and watch our step-by-step video on the JPD of how we took a patient from terminal dentition into a reference denture workflow utilizing milled technology. As I close off the segment today, I want to leave you with a few important notes. Removable fundamentals remain instrumental. Reference denture technique is viable. I showed you one clinical case today that showed you that transition from their old denture into their new denture. This has been the pathway for thousands of clinicians around the world enabling themselves into digital dentures. Let's go back again. If you have an intraoral scanner, you can go ahead and do your impressions inside the patient's existing denture with the bite, scan those records, send it to the lab, you'll get your try-in back, confirm your try-in, make the changes that are needed, rescan if needed, and then get your final denture back. Digital dentures in 3 appointments with a level of precision, efficacy, and accuracy that was never thought possible before. Milling and printing are both options. Post-CAD CAM artistry is possible. Printers and resin technology are advancing very fast. I want to leave you with this statement. Don't waste your time. Go for it. Digital dentures is not the future. It's actually the past and the present. Really and truly, we are continuing to discover new technologies, new innovations, new workflows to truly continue to change dentures together. I also want you to save the date, coming in spring of 2025, my textbook with Dr. Nelson Silva with Quintessence Publishing, which is a digital removable dentures, a true metamorphosis. Can't wait for you to get your hands on this amazing book. For all of you out there looking to discover, let's discover how we'll continue to change dentures together with the reference denture technique and the digital denture workflows.